So Peter, please could you introduce yourself and where you work, please, today?
So my name's Peter. I'm a paramedic practitioner at Mepper Medical Centre, and previously I've been a PCN paramedic and also worked within hospice care and various community teams as well.
Before coming into general, was working in LMN PCN, was that your first kind of stint in general practice, or had you done things before then?
So that was my first stint in general practice full time. Before that, I was part of a primary care home visiting service, which worked on behalf of a GP federation. So I was used to working with lots of different surgeries and doctors, but it was the first time I'd worked within a GP practice itself.
And what attracted you to work in primary care?
So for me, primary care, what attracted me was that you get to see patients from start to finish. So traditionally paramedics, within the ambulance service, see people within emergency urgent care situations, and that's the end of the encounter. So you never get the follow-up, you never generally get to see people again, although you do see some people more regularly, but you don't get to see them from start to finish. Whereas in primary care, they come in to see you with undifferentiated diagnosis like abdominal pain or shortness of breath, and you see them all the way through the process. You order all the tests, you go through, you get the diagnosis, and then you manage them from start to finish, which I really, really like. And it's the detective work. So it's, they come in with abdominal pain, and that's, all you get, and you have to dig into what's causing it and pick the right tests and pick the right diagnostics to be able to find out what's going on with them. I also like the fact that, you have a workload and you're left to manage it. There isn't necessarily the chasing that you get within the ambulance service. Are you ready for another job? Are you ready for another job? You know what your workload is from start to finish. You've got your appointment list and you are left to get on with it. But equally, you have the support then and there of senior colleagues such as the registrars or the GP partners, all of whom are really, really supportive to do what's best for patients, and that's what I really like.
So you've touched upon it. So what does a paramedic practitioner do within a general practice context? What do you do?
So paramedic practitioner falls under the sort of Health Education England bracket of first contact practitioners.
Yeah.
So first contact practitioner will see undifferentiated diagnosis. So that means someone who comes in, like I say, with a presenting complaint such as shortness of breath, for example, and you have to work out what is causing that and then devise management and treatment plans for that patient. It may mean that they've got a chest infection and you need to sort out some antibiotics to treat the chest infection, but equally it might be that you need to order further diagnostics such as blood tests, x-rays, ultrasounds, echocardiograms, all of which are accepted from you as the paramedic practitioner. So it doesn't require someone else to sign it off. You are given the responsibility to do that. But on the flip side, you have the responsibility to read, interpret those tests, and then make a judgment based on that. I see basically everything from that point of undifferentiated diagnosis. There's a few things that I won't see because they're outside my scope of practice. So things such as, gynecology, pregnancy, I won't see patients necessarily in that respect. Complex mental health, I don't see, but I do see, people presenting with their first mental health complaints, and screen them and support them in that respect before referring them on to my mental health colleagues. And I also do ward rounds, frailty reviews, and also the long-term chronic management of conditions such as heart failure, dementia, end-of-life care. So yeah, it's a very, very broad role. From the simple care of a chest infection to the complex and end-of-life care of patients with complex conditions.
Do you prescribe?
I don't at the moment. That is the next step.
Okay. Do you know how long the prescribing course is?
6 months.
6 months, okay.
So it's a master's module. It's a double module, so it's 60 credits module is prescribing.
And outside of prescribing, what other training opportunities are there for you? Or what did you need in order to be able to work in general practice, or did your training cover it?
So your initial paramedic training won't cover what you need to cover to become a practitioner within primary care.
Okay.
You need to have done enhanced clinical assessment, which is your level 6, which is done at various universities, and lots of paramedics do it so that they can move into urgent and sort of primary care. Within 6 months of starting, the framework is that you have to have engaged in a master's advanced clinical practice course. So those at the moment are being funded by the Health Education England taught route. So that's opening up to a lot more people, because obviously funding is usually the crux of the matter. So that is being done at the moment. So that will get you your first 3 modules, which will then allow you to access a prescribing course, which is the way it's gone now. Previously, it wasn't as sort of regulated in a way. So people were getting onto prescribing courses without having done bits and bobs. And don't get me wrong, they were passing prescribing courses, so they're clearly intelligent enough to do it and safe enough to do it. But now what they're doing is saying, no, before you get on a prescribing course, you must have done your advanced clinical assessment modules and at least a module on managing complex patients. Okay. So Health Education England have now rolled out this thing where they say, actually, you can do a PG cert in first contact practitioner, advanced clinical practice, which will then open the door for you to be able to do your prescribing, or alternatively, you can step off the pathway at that point and not be a prescriber. So if you don't want to do your prescribing, you can step off that pathway and you are a first contact practitioner who doesn't prescribe. Or you can stay on the pathway, finish your complete masters and become an advanced clinical practitioner. So there's, there's options there, depending on what pathway you want to take, which is quite nice as well, because I think if people came into primary care and were just said, no, you've got to do a master's in advanced clinical practice, you've got to do this, you've got to do this, I think that would turn off people to it. Whereas if you say, actually, no, you can sit on this pathway or you can sit on this pathway, it depends what you want to do, and you can step off at a point that's comfortable for you. So that's quite nice in that respect.
What support do you need in your practice or PCN to be able to do your PG cert? Because the workload will be significant on both sides, like your day-to-day clinical work and then studying. So what support do you need?
So part of the PG cert and master's program is you must have a clinical supervisor. So either a GP trainer or someone who's done their ACP, has done their full masters and is an accredited trainer. And you need to have at least a minimum monthly supervisions with them. And they are the ones that will sign off a portfolio of evidence to say that you have exhibited the skills that are required to say that you can practice at an advanced level. That portfolio covers the 4 domains of advanced clinical practice, and is a mix of your actual physical, sort of your physical assessment skills. So, the listening to your chests and, all the physical assessment skills. But also diagnostics such as x-rays, bloods, even if you're not a prescriber, to have the knowledge that what should be prescribed in various circumstances and where you get the guidance to do that. So local formularies, national formularies, best practice evidence, you have to exhibit that as well. How you deal with conflict almost in practice. So when you butt heads with patients or colleagues, how you get over those, those bumps in the road, and are able to still practice holistically and still practice within your code of conduct and ethically. And then also about research and being involved in projects. So for my portfolio, the project I did was around RESPECT, which is the national end of life sort of framework that's been rolled out within Kent now and has replaced DNA CPRs. Because of my background, I was involved in that, and then I taught it to my GP colleagues. So, you have to be involved in all aspects of that advanced clinical practice to be able to then pass that course. So that's sort of the advanced practice part of it. So there's a taught part, there's the workplace placement, which is where you're exhibiting that you can do it. And then the other module for the PG cert is the managing and leading complexity. So finding those complex patients. So you're not going to get that without seeing complex patients. So if you only see chest infections, abdominal pain, you know, those urgent on the day stuff, you won't get that, what you need in that final module, which was my experience, because when we did that, it's a group presentation and it had to be one of my cases because the other 3 people who were within my group only see acute on the day.
Okay.
So, you know, you need that broad spectrum.
Do you feel that given the education and training that you've undertaken, do you feel you get to fully, you know, are you operating at the top of your license?
Yeah. Where I work now, I am absolutely. I think the problem, having been on a national course now, because the modules I did were taught nationally via Teams, so it was quite nice because then I got to see people from lots of different areas and how they work. I think it is quite varied, and I think sometimes, partially maybe, you know, paramedics themselves not advocating enough for themselves, but also sometimes the wider community within healthcare not knowing what we can do. And that's been something I've experienced throughout my career, where you turn up and they, you know, and you get, you know, consultants, nurses, doctors, whoever it might be from the wider healthcare community going, oh, well, you can do that, can you? And I think that's still a little bit of it. There's such a wide range, which is why the Health Education England sort of framework says, no, if you're at this level, this is what you can do. Which I think is why it's really important, because I think up until now it's been very individual, and there are some people who absolutely, you know, have more knowledge in one area than another. My example is that I have a lot of knowledge within palliative and end of life care. I've worked in a hospice, so you know, that's my area of expertise, whereas some of my colleagues have got no experience in that. So it's still very personal, but it's good that we're getting this sort of benchmark of, if you're in this level of practice, this is what you're expected to do. So yeah.
Do you think that there are opportunities? So where you say you've got the expertise because you've worked in a hospice, so it makes sense for you to get involved in the frailty stuff and the enhanced care and care home. But if I was a paramedic that didn't have that experience, it's like when you say you have to learn to advocate for yourself, how does somebody get the experience? How do they broaden their role when they don't have the experience? What do you need to be able to do that?
So I think you need the ability to step up and take a leap sometimes. And when, you know, if you only see a very narrow spectrum of patients, you will never broaden that. So when I started within the PCN, I went out with, at the time, the doctor that was doing the ward rounds within the care homes. So what I did was I went out with them and built up my knowledge alongside them. And then once I was happy, went and did it myself. So I think you have to be open to almost stepping off and out of your comfort zone and going, actually, I need to do this. But what is nice is because you've got GP colleagues around you, and as long as you've got very supportive GP colleagues, you know that I can just go and knock on one of the doors and go, I haven't seen this before. I don't know what it is. And they will come in and they will say, okay, let's have a look. Right, this is what it is. And then you go away, and you've got to be willing to then go away and learn. So if you haven't seen something before, you've got to be willing to go away and go, right, in my own time, I've got to read up on this so that when I see it again, I know what it is and I know how to manage it. So there's a lot of emphasis in advanced practice of your own development. So you've got to be willing to go and, you know, do those courses, go and do that reading and that research to improve your knowledge. And the thing about primary care I found is almost every day is a school day. And that's not just for me, that's my GP colleagues as well. Because we had someone the other day who had to have been bitten by a cat in some, you know, Middle Eastern country. And then we were told, oh, well, you've got to do rabies, immunoglobulin. And we all looked at each other and went, not a clue, including the senior GP partners who all went, no idea. So we all had to go away, sit down and read up on it. So it's not just us that have to do that, which is really nice to know. Our GP colleagues sometimes will go, not sure. But equally, they'll also defer to you if it's something that they know you know more about. So I find paramedics know are a lot more attuned to sort of the sometimes social needs of patients.
Yeah.
So when we go and do home visits, we see people and what they need. So therefore, we're a bit more attuned to what we can get support-wise in terms of social and care needs. And quite often, my GP colleagues come to me and go, "I've got this. Who do I refer it to?" Because you know the social care pathways. So who is the best person to deal with this? So that's really nice as well. So we play off each other's strengths. But yeah, like I say, you have to be willing to go and do that reading. And when you don't know something, just say, "I don't know, but I'm going to go and find out." And then that builds your knowledge again and again and again. So yeah, you just have to be willing, but you also have to advocate for yourself in that you have to be willing to say, "I don't know," or saying to, if you work in a practice, actually, these are the things I'm not comfortable seeing. So for example, I will say, "I don't see any under twos in terms of children. I'll see anyone 2 and up. I haven't got an issue with that. But because of the complexities of much younger children and babies, I don't see them." That is for a doctor to see. And that's me. That's just said, no, that's where I'm drawing the line.
So there's a scope of practice, but also you've got the freedom and flexibility to say, I'm not going to do X, Y, and Z.
Yeah. So I'm not going to do internal exams, for example. So I'm not going to do rectal exams. I'm not going to do vaginal exams because I'm not experienced enough, and I don't feel I know enough to be able to do those things. And equally, patients generally want to see a doctor for something like that, and I haven't got an issue with that at all. Okay. So it's about finding where your line is, but being very, very open to expanding your scope. So at some point, I am sure that I will have to do rectal exams and things, but that's where I then have expanded my scope through further learning and experience, rather than I think the issue within the difference between sort of paramedics, so allied health professionals such as nurses, paramedics, we're very much that taught route where we get taught something and then we, experiential learning where you go and have placements and all those sorts of things. The difference is between that and our doctor colleagues is that doctors have this thing of see one, do one, teach one. So they get shown it once by a senior doctor, they then do it, and then it's like, all right, well, there you go, you've done one now, so off you go. And then when the next junior colleague comes along, they go, well, you've done it already, so you go and teach that one how to do it. So, and I think that's sometimes where the lines are a bit blurred, because I think the doctors are so used to that, they're like, well, you've done it once, so it's fine. It's like, it doesn't mean I'm competent to do it. So, and I think that's where the difference is between, but like I say, where I work, my GP colleagues are brilliant, and they are really, really, really supportive. So
what does a good induction look like? I'm brand new to general practice, primary care. I'll say general practice. What does a good induction look like?
Working with everybody within the practice. So doing, for example, a new paramedic coming into our practice will sit with me, but they'll also go and sit with the GP. They'll also go and sit with the nurses. They'll also go and sit with the healthcare assistants. And what also would be good is to go and sit with the secretaries, so that you have an understanding of every single part of practice. Because I think for me, that was one of my things when I came into primary care. There wasn't a great induction. So it's like, they said, well, you just dictate a letter, don't you? And I went, I've never dictated a letter in my life. I don't know what you're talking about. So it's getting that understanding. Whereas now, pick up a dictaphone, done. So it's getting that understanding, because there's lots of different things. And I think the other thing for paramedics in particular is there's a much greater emphasis on sort of management, obviously outside of hospital, and this watch and wait sort of principle within primary care. So you prescribe some medication because they've got a chest infection, even if it's quite a severe chest infection, it's not necessarily just send them straight to hospital, So I think for paramedics, because they're so used to this quick fix of take people to hospital and things like that when they work with the ambulance service, you have to get your head around that. And it takes some time. It took me some time as well, because I was like, oh, this person's really unwell, but hang on a minute. No, we're not going to send them to hospital. If I'd come in an ambulance, I might have done, but actually I need to get my head out of that world and into this world where actually we manage them at a much higher level with more medication and things like that, and try and keep them out of hospital, or use some alternative pathways to get them support in their home. So the induction across all areas, but also getting your head round, actually, you have these complex patients, and actually sending them to hospital isn't the right way. You need to manage them at home. So yeah, that's getting your head around that is the big thing. And going out on home visits. So when the registrars, we're a teaching practice, so when new registrars come in, they come out with me on home visits, and it's an eye opener for them, because they're used to a hospital or a clinic with 4 clean walls, and then you go into, a house with hoarding or alcohol problems or other substance misuse problems, and it takes their breath away usually, and they go, "Ugh," and I'm like, well, but this is reality. You have to go into these people, and even if you wouldn't choose to live like this, they do. So you just have to get on with it. So I think that's the important thing for induction across everything, is to sit with all these different people and understand what everybody's role is. Because with the expansion of clinical pharmacists, advanced physiotherapists, all those sorts of new roles, I think you need to sit in with all of them so that you get an idea, even if it's just half a day, so you know what they do, so that you know when is the best time to refer to them for something, and not try and take it all onto you. I think that's one of the things I learned within primary care quite quickly, is actually you've got all these other specialties around you. When is the time to say, actually, I'm going to make you an appointment with, the musculoskeletal team, rather than me? Because actually, yes, I can tell you that you've got arthritis in your shoulder, but actually to manage it more long term, you need physio. Yeah. So it's learning all these different pathways that are open to you. It's one of the biggest things within primary care.
Okay. Before we started recording, you mentioned obviously the end of the financial year, you were working on QOF. Mm-hmm. What things are you doing to support that?
So with QOF, as you know, it's basically key performance indicators of how we manage conditions, and how well we've managed the long-term chronic conditions such as diabetes, heart failure, dementia reviews, mental health reviews. So part of that, where I am at the moment, is I take along a lot of the functional reviews around that. So I see heart failure. So every year, heart failure patients should have a functional review. So I should come and see someone. We should talk about how their symptoms are affecting their day-to-day lives, up-to-date lifestyle, so weight, height, how their diet is, so it's a real holistic view of what's going on. It's not just how you're getting on with your medications. Oh, that's fine, then carry on. Yeah. It's more, how is everything going for you? And it's the same with the dementia reviews. So the dementia reviews are, it's not just about, how's your memory? It's actually how you're doing with your everyday, any problems with continence, any problems with eating, drinking, any problems with sleeping. And again, height and weight, and blood pressure checks, and do they need annual bloods because they're on other medication. So it's looking at the entire picture of the patient. So when it comes to QOF, I've taken on those cohorts of patients. They come and see me for half an hour. If they're housebound, I'll go and see them at home, just so that we can get a proper overview. Because I think what's happened with COVID is, because everything's been done remotely, we've lost that completely. Because if you phone a patient, how are you doing? 9 times out of 10 on the phone, oh, I'm fine. Whereas when they come in to see you, it's a completely different ball game, because you can see as soon as they walk in the room, if they've got heart failure, are they really short of breath as they walk in the room? Yes. Whereas if you speak to them on the phone, well, they're sat down resting, so they go, oh, I don't really get very short breath. Whereas you can see a lot more difference. So that's what I've taken on board with that. And also the annual structured medication reviews for the care homes I do alongside my clinical pharmacist colleagues. Yeah. So they review the medication, but because I know the patients, because I see them every week on ward rounds, I'm there to say, actually, no, alongside the care home advocating for them, we can say, actually, in this case, this is how this patient presents. So actually, we could probably stop that medication, or we could reduce that medication, or actually, they need to be converted to liquid. So that's where I get involved in from a QOF, IIF sort of perspective, and I do the weekly care home ward rounds, which is part of the EHCH criteria.
Do you do the weekly ward round by yourself, or do you have a GP colleague? You do?
No, I do it by myself, and then we sit down and have a chat after I've been with whoever the named GP for the care home is, and discuss any patients we need to discuss. So a lot of the patients I see don't necessarily need discussion with the GP because it's, maybe we think they have a urinary tract infection or a chest infection, which is something I can manage. If it's some of the other patients who are more complex and needs that GP input, and we need to speak about their medications and things along those lines, then we sit down and we discuss them after I've been on the ward round. So the GP is involved, but I've got the time, in essence, in my day blocked out so that I can go and see the patients and give them a lot more time than the GP would be able to. Simply because with the GPs, it's just tacked onto their day somewhere, in essence. Whereas for me, it's protected time where that's when Pete's going into the care homes. So therefore, I can spend 20 minutes, half an hour with a patient if I need to, whereas the GPs don't get that luxury as such. So yeah, that's the way we work it. I then also do one of the nursing homes. We've got a very high proportion of elderly, complex mental health patients, not dementia. These are people with, severe psychosis and long-term conditions where quite often they've been inpatients in hospital, under detention, under the Mental Health Act for a long time. So myself, the care home, and the older adults mental health team, doctors and ACP, we do a monthly ward round together just to review that cohort of patients. So again, we come at from an MDT point of view, because a lot of these patients are on medications that actually, even within general practice, we've got no idea what to do with, quite frankly, because they're unlicensed or they're being used in a way that require a consultant overview and a psychiatric overview. So we do that monthly as well, just because we identified that actually there is a large proportion of patients that we don't necessarily meet the exact needs of, whereas the mental health team, absolutely, that's who needs to be involved. So yeah, that's the way we work it where I am.
Couple more questions. People will be watching this. If they don't have a paramedic practitioner, they'll be thinking, oh my God, where do we find a Pete? In my experience, trying to recruit paramedics has been really, really challenging. Is there any advice you can give us? Like, where do we find, and what do we need? It's not a competition, but how do we compete with other networks and the ambulance service? How can we get people like you to come in?
So I think one of the things is a lot of us have come across from the ambulance service partially for a work-life balance. Okay. So in the ambulance service, you're working 12-hour shifts, which are always then extended to 14-hour shifts. And then, you don't get that balance. You're always off late, etc. Whereas in primary care, you don't get that, especially where I work. Actually, my doctors are brilliant. They say, look, yeah, it's the end of the day. Have you done everything that you need to do that needs to be done today? And the rest you can pen till you're in next. And actually, that was something I struggled with massively, but it is absolutely true. And that helps my work-life balance. I know at 6:30, I'm gone. I'm home. I go home at about 6:30. I work full-time hours over 4 days, which is exactly the same as my GP colleagues. So I've negotiated that. So I do, in essence, 10-hour days, but when you factor in your unpaid break, then that equates to 37.5 hours a week. So like on Friday, I finish at 6 rather than 6:30 because we've just worked out the timings in that respect. So it means I get a day off in the week, which is great, which I think is something that when I first came into primary care, where I was working 5 days a week, weekdays, was something I missed. So when I came into my current role, that was one of my things I said at interview. I said, I want to work 4 days. And they turned around and went, well, everybody else does, so that's fine. The other thing is, I think people are very used to, in the ambulance service, the unsocial hours payments and that sort of thing, which you obviously don't get within primary care because you're not working unsocial hours. So I think that's the big thing. So when you first come into primary care and you're doing your you just stepped into it, it is a band 7 role. Problem being that band 7, the top of band 7 is great, but the bottom of band 7, actually, because paramedics at the top of band 6 are then getting unsocial hours benefit, they actually lose money coming into primary care. So I think that's, you know, in this current climate, I think that's a big thing for them. So I think it is partially monetary. And I think the other challenge is so I found when people are recruiting paramedics, if you've already got a paramedic in your surgery, for goodness sake, put them on the interview panel.
Okay.
Because that hasn't happened several times.
Okay.
And then they've said, oh, well, we've just recruited this person. You went, right. And did you ask them this, and this? No. Right. So, you know, I think that's where the issue comes a little bit. And I think one of the things we could probably do a little bit better is get paramedics to come and sit in with paramedic practitioners in primary care. So I had someone who came in and sat in with me recently. And he was just flabbergasted by the amount that I do in my role, compared to what he does as a frontline paramedic on an ambulance, you know. So I think people don't always have that clear expectation of actually what the role includes. So I think people need to be more aware of how much responsibility and just how much you will see and be expected to see when you come into primary care. So yeah, I think there's that element of it as well, where people just aren't quite sure about the role. And I think that's across the healthcare service. Paramedics have only been around really since, you know, the late 80s, early 90s. And in the current roles that they're doing now, probably only in the last 10 years. So people are still unsure of what necessarily we do. I say to people, if you think advanced nurse practitioners, just replace the word nurse with paramedic. So an advanced paramedic practitioner, advanced nurse practitioner do very much the same thing and see very much the same things. But everybody's used to A&Ps. People aren't used to paramedic practitioners. Okay. So yeah, it's that expectation and realization of what people can do, I think, a little bit. But yeah, certainly from a recruitment point of view, I think money is a big thing. But I think most of us come into primary care for that increased clinical responsibility because we want it and we want to develop. And I would say to everybody, there's massive scope to develop where you are supported in primary care. So if that's what you want to do it. And the work-life balance is so much better. I thought I'd never get used to not working shifts and, you know, these big blocks of days off that you got in the ambulance service. You did 4 night shifts, 12 hours, and then you got 5 days off. And it was like, hey, brilliant. Well, actually, I get 3 days off a week. And actually, by having the evenings as well, all these things that I didn't used to be able to do, like go to the cinema in the evening or go out for the evening, I can do now. And it makes a huge difference to your work-life balance. Massively does. So, yeah.
How do you interact with your PCN colleagues?
So within PCN colleagues, so I meet weekly with our frailty PCN nurses. They also are involved when we have sort of our monthly MDT meetings. So we still interact on that basis. The CEF leads, sort of send me bits and bobs as things go on. I do find sometimes that it is a bit fractured within that, but we do still talk. We see each other at protected learning time every month as well. So yeah, we certainly do interact from that point of view. There is a PCN paramedic practitioner being recruited at the moment, and when they come in, as has been previous, we work alongside each other and try and cover each other as much as we can in terms of, if I'm not there, then can they do the ward rounds and that sort of thing. So yeah, we interact like that. And the same with, so the clinical pharmacists are all employed by the PCN. So I see them and we work together to do meds reviews and care home reviews. So yeah, we interact on a daily basis.
And I was going to say, in regards to your appointment book, so where you say you control your workload, do receptionists book patients into yours? How does it work?
So at MEPM, we have a full clinical triage system. So when you contact the surgery, whether you phone, come in, or do an e-consult online, everything goes up to, like, in essence, a care navigation service, which is overseen by myself and the GPs. So there are very, the care navigators are brilliant because, abdominal pain, etc., unwell children, they, straight away they're saying, right, this needs to go in for a face-to-face with a GP or a face-to-face with Pete or a telephone call or whatever it might be. And they put those directly into all of our diaries, in essence. We have control over our diaries in that. So I have routine telephone appointment slots. So if I need to follow up a patient, I can book them directly into my diary. If I need to book in home visits, I have slots where I can go, no, I need that for a home visit. So I'm able to manage that in that respect. And equally, if I speak to a patient in the morning on a telephone call and I go, actually, I need to see you. I'd really like you to come in face to face. I can find a slot later in the day and go, I'm going to book you in at 4:30 in my afternoon clinic and you're going to come and see me. So I've got that sort of balance in that respect. And then my ward round days, I've got complete control over the diary and my ward round days to make sure I'm following up the patients that I want to see, but also that need to be seen from the care home's point of view. So I've got that complete flexibility to do that. I can book forward in my diary as well. So if I see someone, our books, I think, are now open about 5 weeks ahead so that we can book those routine follow-up appointments later on. And again, I can just book directly into that. I can also book directly into my clinical pharmacist colleague diaries and all my colleagues' diaries, basically. So if I see someone and they say, oh, also I need a meds review, could you sort out that for me? I go, give me a second. Right, in 2 weeks' time, I'll get the clinical pharmacist to give you a call and I've booked you into their diary. So we're all the same. GPs book into my diary if they see someone and say, actually, do you want to come and see Pete? And, so we're very flexible in that respect. And also equally, if I see someone and I go, you need to see a GP, I'm allowed to look through the GP books and go, you need to go and see a GP and I'm going to book you in to see this GP on this time, day, date. So we're all very flexible in that respect and we can move things around as we need to. Same as booking in blood tests with the nurses or ECGs or whatever it might be. So yeah, we have that flexibility. My diaries are set up exact mirror of my GP colleagues.
Okay.
So I get protected time at the end of my morning clinic to catch up on the admin and my results and everything else at the end of my morning clinic, and the same at the end of my afternoon clinic. So you don't feel, if you can get it done then and there with the patient, great. But if you can't, you know that you've got some protected time to be able to catch up on it and do it. Because what I would say to people is when you come into primary care, and you start doing all the diagnostics and things like that, it takes on a whole other workload in itself. So quite often on a Monday morning, because we've had the weekend, I'll come in and I'll have 30 blood results that I need to look through and work out what we're going to do with them. Are they normal? Do we need to do anything with them? Same as X-ray and ultrasound results and things like that. So that's why it's good to have that protected time built into the diary. And that's simply because I sat down and said, this is what I need. So again, it's application.
Would you benefit from any administrative support?
So I think admin wise, within the surgery, they do a lot of that from sort of the admin and office team. So what's really good is they already filter all that through. So they make sure that the blood results that are coming to you are yours. They make sure that the ultrasound reports that are coming to you are yours, but they also make sure that actually if there's a letter addressed to you and it's just for your information, they'll just send you a little note saying it's just an FYI, you don't need to do anything with it. So that from that point of view, the administrative support is really crucial. But the stuff that comes to us is clinical things, which is great. So yeah, you do get that support and that's really good.
It sounds like a dream, Pete.
It's what I like. I really love my job, and I really love my role. I would say it's probably not for everybody, and you have to be willing to take that leap and that step. So if you told me when I started in the ambulance service, 10 years ago, that I would be doing all this, I'd say you're completely mad. But actually I am. So, I think that's what I say to people is there's that scope to go as far as you want to go. I've got colleagues that, have now decided that they want to go and do their medical degree and are doing that, so you can go as far as you want to go with the support that's available. So, yeah, do what you want to do. And if it's what you want to do, I love it. I love my job. So, yeah.
We'll end there. Thank you so much.
You're very welcome.